Good afternoon, everyone, and welcome to today's special Fireside Chat in recognition of Colorectal Cancer Awareness Month. I'm Mamna Hussein, the Community Outreach and Engagement Manager at the Masonic Cancer Center here at the University of Minnesota, and I will be your moderator today. It's my honor to be here for this important conversation on colorectal cancer. We'll be covering everything from prevention and screening to treatment and survivorship. The Fireside Chats are brought to you by the Office of Community Outreach and Engagement at the Masonic Cancer Center at the University of Minnesota. The Office of Community Outreach and Engagement serves as such a vital bridge between the Cancer Center and communities across the state of Minnesota and beyond. Our team is committed to reducing the burden of cancer by actively engaging communities and providing access to relevant knowledge on the latest in cancer research, prevention strategies, the importance of screening and early detection, treatment options, survivorship, and opportunities for clinical research. Today, we'll explore the growing concern around early onset of colorectal cancer. We'll address barriers to screening, advancements in treatment, and the impact of advocacy. This conversation will be interactive, so we highly encourage you to stay engaged, ask questions, and take away as much valuable information that could help you or a loved one. So it is now my pleasure to introduce our first speaker today. So we will be hearing from Dr. Emil Lou. Dr. Lou completed his undergraduate degree in biochemistry at SUNY College before earning both his MD and PhD degrees at SUNY Upstate Medical University. He trained in internal medicine at Duke University Medical Center, followed by a fellowship in medical oncology and hematology at Memorial Sloan Kettering Cancer Center, and an additional neuro-oncology fellowship. As a physician scientist at the University of Minnesota, Dr. Lou's research focuses on how cancer cells interact within tumors and what drives treatment resistance. His work aims to translate laboratory discoveries into more effective treatments for colorectal cancer patients. He is also a key leader in K-SPY, a national clinical trial platform designed to improve and personalize colorectal cancer treatment options. Both Kim and Dr. Lou will be talking a little bit more about K-SPY. Dr. Lou actively contributes to national and international research collaborations focused on advancing cancer treatments. So in addition to his clinical and research roles, as mentioned, Dr. Lou is board certified in medical oncology, internal medicine, and neuro-oncology. So Dr. Lou's extensive expertise in both patient care and research is truly remarkable, and we are so grateful to have him here with us today to share his insight. I mean, his work is truly shaping the future of colorectal cancer treatment, and we look forward to hearing more from him. So following Dr. Lou's brief presentation, we'll hear about the remarkable journey of stage 4 rectal cancer survivor and passionate advocate, Kim Newcomer. I'll introduce Kim a little later on in our program today. All right, so before we dive in, let me just cover a few quick housekeeping items. So today's Fireside Chat will be recorded, and the recording will be made available on the Masonic Cancer Center's YouTube page sometime next week. So please share the recording widely for anyone who you think might benefit from it. For any University of Minnesota employee or spouses participating in the university's employee well-being program, you can earn 200 well-being points by completing the form that will be linked in the chat shortly. And again, this is going to be an interactive conversation, so please use the Q&A feature at the bottom of your Zoom screen to submit any questions or comments that you have throughout the session. We have time carved out at the end to take some live questions. All right, and now without further ado, I'm actually going to pass the floor to Dr. Emil Lou.
Thank you so much, Amna. It's an honor and privilege to be here, and big credit and kudos and thanks to all of your colleagues in the Office of Community Outreach and Engagement and everyone at the Masonic Cancer Center. I think during this Colorectal Cancer Awareness Month, what the Masonic Cancer Center and the office is doing to amplify the message is crucial. For many people have signed up, so we're grateful for all of you attending from near and far. Good afternoon to those of you who are on a time zone that's afternoon, and maybe even those who might be joining from other coasts in the morning. So good morning, good afternoon to all of you. So I will go ahead and share some slides. And really, I am especially thrilled that Kim agreed to partner with me on this. So I've known Kim for a long time through various forums and through some exciting developments that we're both going to talk about, and we'll also continue to discuss some initiatives about K-SPY and Colorectal Cancer Alliance, um, really helping to drive that. And so we're just thrilled to have you join us here at the Fireside Chat. I wanted to begin by raising awareness and also just thanking many advocacy groups that are raising money for colorectal cancer research. They're helping to drive patient programs to help patients and caregivers affected by colorectal cancer. And I think what's so remarkable about being in the Twin Cities is that there's a lot of activity here, and some of these organizations are centered right here in our front yard, backyard. So special thanks to Colon Cancer Coalition. They provided a great swag. So check your colon, as our logo says, and the buttons to reflect. So um, happy to share the message by wearing and also talking about it. Going clockwise, Project Cure CRC is an exciting, extremely innovative endeavor that we're going to talk about that's really going to, we hope, move the needle in a larger way than has ever been done before at a national level. And for the Masonic Cancer Center at the University of Minnesota and our clinic to be involved in it is really pivotal for the upper Midwest and at the national scene. The MCCRF, the Minnesota Colorectal Cancer Research Foundation, raises money, including through their annual gala and other events throughout the year. I'm proud to be an advisory board for MCCRF, a member, as well as for Colon Cancer Coalition. Coates Colon Cancer Research Fund, likewise, for over a decade plus, has also been instrumental in raising money for research done here at the University of Minnesota. And we'll briefly probably mention another link that Kim and I have, and that we both have the privilege to participate in April. The AACR is the world's oldest cancer research organization. Their annual meeting takes place usually in April of each year, and the Scientist Survivor Program for more than 25 years has welcomed several dozen um, cancer patients who are going through cancer treatment or have survived it, are thriving, and they come to the AACR annual meeting to interact with scientists. And it's very much the case where they really teach scientists what the patient experience is, and it's just invaluable. And so Kim and I will be participating in it as we have in many years past, and also this coming April. So let's chat a little bit about incidence and statistics and start and go from there. The American Cancer Society puts out an annual report on statistics, and there's really been a steep rise in colorectal cancer among young adults in recent years. And that it's been in the national news so much that it may not be a surprise to everyone in the audience. It may still be a surprise, but it's something that we're recognizing. When I trained as an oncologist at Memorial Sloan Kettering Cancer Center, it was really kind of just put in that basket of people who are older or affected. Cancer is a disease of aging. And so the mean or the average um, statistics, the average age of colorectal cancer diagnosis, late 50s, early 60s, and that's changing, with 1 in 5 cases being in people 54 years or younger. And that is rising despite the overall landscape of colorectal cancer. Just when you look back in decades past, if you look at the overall rate, is going down a little bit, and that's promising. And people are living longer, but at the same time, the rise of the last 1 to 2 decades has really caused a lot of alarm. We just don't know why, and that's why research is really essential. A lot of research is going in that direction. But when I tell patients, when I first meet patients, I just give a general overview. I cite that there are approximately 150,000 new cases of colorectal cancer in the US each year. That's a lot. It's definitely within the top 3 new cancers. And so if you think of now in March, Colorectal Cancer Awareness Month 2025, compared to a year from now, there are 150,000 people in whom cancer is brewing, and by a year from now will have been diagnosed, that may or may not have symptoms. And let's talk a little bit about that, because it would be intuitive to think if someone has cancer, whatever stage it might ultimately be diagnosed with, that they would automatically have symptoms, and that is a route that people will be, that will lead to a diagnosis. But with colorectal cancer being one of the few types of cancer for which we have effective and validated screening tests, I'm just seeing more and more, especially in the young adult population, people getting a colonoscopy or other types of colorectal cancer screening, and they're saying, I didn't have any symptoms. And that's becoming less uncommon. So some of the signs and symptoms through this beautiful graphic from the Office of Community Outreach and Engagement here at Masonic, it might be some, it might be one, it might be all of them, whether it be rectal bleeding, which can easily be mistaken, overlooked as hemorrhoids or something else. And yes, we're going to talk about poop because that's what we do when we talk about colorectal cancer, we have to be open about this. Um, Anemia, whether it's something that causes symptoms or not, or detected on a routine blood test, changes in bowel habits. Again, yes, we have to talk about diarrhea or constipation. We have to get used to talk about this with other people, including our primary care doctors or other primary care providers, and being open about it. And at the same time, advocating for oneself. It's hand in hand with educating the public, very much includes educating other doctors, other medical providers at all levels, not to dismiss some of these symptoms or any of these symptoms as just being things caused by things that are not cancer. And that's just the practical reality in the 21st century that we have to live with. Other risk factors, older age, uh, inflammation that lasts over years, what we call chronic inflammation, some of the more common causes of that, Crohn's disease, ulcerative colitis. And you all might know people who've had this, even if you don't have, if you're diagnosed with it or know someone diagnosed with it, and they might say, no one in my family ever had diagnosis of colorectal cancer. How can this be? A statistic I cite to patients, because I know it's whether they ask it or they're thinking it or hadn't thought of it yet, under 10% of cases of colorectal cancer align with known um, what we call hereditary syndromes. And there are some yet to be discovered, I'm sure, but it's really, I guess the point is it's not 50%, it's not 90%. That leaves a lot of opportunity for us to know about the things that are more well known, smoking and alcohol consumption, eating red meat and processed foods. And I'll talk a little bit about that, with, especially with highlight in alcohol, because that's something that's very been much present in the news in 2025 with the outgoing or the previous Surgeon General under the previous presidential administration, highlighting that in January 2025. Some of the screening guidelines, I know people automatically think about colonoscopy. 45 is the new 50 has been a catchphrase since 2018, when the American Cancer Society and numerous other professional medical organizations shifted the recommended first age of diagnosis, or I'm sorry, of screening for potential diagnosis from age 50 to instead age 45 in the absence of any symptoms, and maybe sooner if there's family history of colorectal cancer, or sooner if there are symptoms. Who should get screened in general, just broadly, 45 to 75, colonoscopy. And yes, there are other tests. There are ones where you take home and then stool samples will be placed on cards and sent back to medical testing facilities that can tell you whether or not suspicion is low enough to defer colonoscopy potentially, or others. But at the end of the day, it really, what I will use the word partnership throughout the conversation. Partnership is absolutely essential with your primary care physician or equivalent provider to have that conversation and to advocate for oneself. Prevention, we'll talk a little bit more in depth. This is a little bit of a preview, but knowing your family history, controlling the things we can control. We can control our diet, to some extent, and I realize there are many, many factors that go into that. Availability and affordability of food, of course, we have to recognize. Intake of alcohol is increasingly being linked to colorectal cancer incidence and many others, breast cancer, and at least half a dozen that were mentioned in the U.S. Surgeon General's report in January. Exercise, it's, you don't have to be out doing a triathlon and a marathon, but being active physically makes a difference, whether someone's already diagnosed and potentially impacting the outcomes and improving the outcomes, or just in terms of decreasing one's risk to the extent possible, as opposed to a sedentary lifestyle. All of this is important. And, just come back to this idea that in addition to breast cancer, where mammograms are recommended for women beginning in that 40 to 50 age range, colorectal cancer, it bears reminding, it's one of the few cancer types that that were accessible, validated methods of screening for. And so early detection is key. The intent to try and find a cancer earlier, especially when someone doesn't have symptoms, and to try and go for an intent to cure, as opposed to finding it later when symptoms develop and to a point where it may not be curable at that stage. We discussed some of the symptoms, and people may not have all of them. People may have some of them or just one. And things like abdominal pain are very nondescript. They're not specific. There are many things that can cause abdominal pain. So a phrase sometimes I use is, in the absence of other causes. Food poisoning can last 24 hours. People get a viral illness or gastroenteritis that can resolve usually on its own within a few days, but cancer-related abdominal pain does not just go away on its own. And that really, waiting months to have that detected can have a bearing on how it can be diagnosed and treated in a timely manner. So what is going on? Really, with this rise of CRC, colorectal cancer in young adults, it's also referred to as early onset. There's very much a growing recognition, especially in the last 5 to 6 years, if not longer, that it is a growing there's a growing percentage of the population diagnosed with colorectal cancer that is particularly young with less explainable causes. And I've had all too many patients tell me I do everything right. I bike 8 miles a day. I don't drink alcohol. I don't smoke. How could this be? No one in my family ever had colorectal cancer. And that can all be true. And at the same time, people are being diagnosed with colorectal cancer. And the risk is we're finding more and more that it could be more aggressive and difficult to treat, a higher proportion of these cases being detected at advanced stages. The risk factors, as listed, are really subjects of important research. And then something that's coming to bear is American Cancer Society a number of years ago came out with a study saying that colon rectal cancer, there is a 2 to 3 higher proportion of risk for people born around 1990 compared to people born in the 1950s. And so, as a researcher, I put on my research hat and I think, well, what's different about society? Tobacco and alcohol were around. That's on the decline in terms of use. Obesity, diabetes has been on the rise. Less activity, a more sedentary lifestyle, just very globally. But I think of environmental exposures, and whether it be in Minnesota or any other pocket of the country, whether it's chemicals. And 2024, I thought was really an eye opener for me, reading articles in major news outlets talking about microplastics, fertilizers, and the exposure. And we're really just at the tip of the iceberg right now in understanding how that might impact colorectal cancer risk, but I think it's a very real potential risk. But things that we can control, reducing or eliminating smoking and alcohol use. Having a sedentary lifestyle is not separate from that, but it's also beneficial for heart disease and other disease. But it's kind of this cycle where if we have a sedentary lifestyle and it increases our risk of diabetes, diabetes is linked as a potential causative or at least an associated factor with colorectal cancer and many other types of cancers. So these are things that we try to control, and with increasing recognition of the extent of processing our foods as compared to more natural fruits and vegetables, and getting kind of that FDA pyramid of recommended servings of each of those, in addition to grains, can really reduce our risk. And more studies are being done in that regard, and really shedding light on the importance of that. But there's a lot of ongoing, in the sphere, what we call cancer prevention research. There's a lot more to be done. Taking from that report from the Office of the Surgeon General that I mentioned, consuming alcohol increases the risk of at least 7 types of cancer, and colorectal cancer is one of them, as you see. This I took from a major oncology review that came out in 2017, published in Journal of Clinical Oncology, that the relative risk of alcohol drinking for several different cancers, and I highlighted colorectal cancer here for moderate and heavy drinking. So that's nearly 1.5-fold is what it says when it says 1.44 in the lower right-hand corner. So there is no mistaking that alcohol is strongly associated with this. And our overseas counterparts, especially in Europe, years ago, came out with more firm recommendations, and professional organizations in the US are coming out with this as well. But this is really, over the last decade, more strong recognition of the potential for heavy alcohol or even moderate alcohol intake to increase risk of colorectal and other cancers, and calling for what decades ago came about with the cigarette and tobacco industry, more forceful legislation and more forceful awareness for the general public of the potential association. So these are not the only 4 ways that alcohol could, but people often ask, well, wait a minute, especially if people are skeptical and saying, and I'm recognizing that alcohol use is prevalent in the United States, and it can be honestly kind of without creating a defensiveness when it is brought up. Sometimes people might naturally feel that is not true, but there are multiple ways at the individual cell or cluster of cell levels in tumors that alcohol exacerbates what we call metabolic stress or other things that it has been elevated to the role of carcinogen, a cancer-causing agent, not associated with as an innocent bystander, something that potentially exacerbates it in a major way to drive an aggressive cancer. This has been well known, obviously, for lung cancer, head and neck cancer for decades. Now bring this to the forefront for colorectal and other cancers is a major advance in knowledge, but it also the impetus to educate the general public is really huge. So 45 is a new 50, and it was changed in 2018, and we're going towards three-quarters of a decade in that. And that guideline may change yet again with more research because and even in my own patient population, the youngest patient I've had is not 45 or older. I've had patients in their 20s, even teens, if you can believe that, 20s, 30s, and earlier part of 40s, who otherwise had no reason to get a colonoscopy before the age of 45 until they developed symptoms that needed examination. So colorectal as a potential cause for any of the symptoms that we described has to be on the mind of people and also the people who take care of them at primary care clinics. And so we have to educate everybody about this. There are barriers to screening and barriers to care in any aspect of healthcare. Cancer is no different, and care of people with colorectal cancer is no different, unfortunately. And this is where the Office of Community Outreach and Engagement from our center is really taking the lead role. And we recognize that in our state, the constituency, University of Minnesota's purpose in being here is to serve the people of Minnesota in so many ways, but the higher rate of this cancer in racial and ethnic minorities whom we serve in the Twin Cities and greatly beyond, and even I would say venture the upper Midwest, is something that we're trying to address. And I'm saying everyone here at the Masonic Cancer Center, everyone here at any academic center worldwide, really, so many people are trying to tackle this problem, and equitable access needs to be the result, and that's key. And trying to recognize the needs and have dialogue that is respectful and more listening than talking at people is absolutely essential. We have such a heterogeneous population, Twin Cities. I am told statistically that we have the largest population people of Somali background outside of Somalia, and a large Hmong background and Native American communities whom we serve. And part of the outreach, and I'm not going to certainly speak to it during question and answer if there are questions about it, the mobile colorectal cancer research community screening program. I put the QR code in addition to the website for anyone. I'll pause there if anyone wants to bring up their phone and have a direct link. But I think this is an example of immense teamwork and partnership between local groups of community leaders that stems from trying to meet the need of what people need in our community and also listening to what the needs are. So it's a dialogue, definitely not or always trying to improve to get there. So late stage diagnosis, points to consider. Sometimes when um, it can be always a shock. I mean, some degree or another, really, to a patient and newly diagnosed with such a disease, the people who care for them, caregivers could be parents, spouses, children, grandchildren, people from their faith community, anything. It's like neighbors, caring neighbors. I've seen it all, and it's really having that support network is key. And when people come to our clinic, I want them to know, or I try to express, and I try to form for them. I say, the support system, we will be part of that and support you and their caregivers and our nursing team, our physician assistant. We have a large number of people, pharmacy teams, and I would say, I'll tell patients, there's a large number of people who are your support system you never get to meet, but we are here to support you. And we also want to impart hope. Over the past decade, clearly after the time I trained, the I would say in colorectal cancer, the advances are light years beyond what was present 10 to 20 years ago. Many patients are living longer with better quality of life. And self-advocacy, I would say in partnership, we meet in the middle and we each kind of do 50-50, sometimes 60-40, sometimes 80-20, whatever it is, but we're here to support, and the central point of care is listening to patients. And that's key for survivorship. I have many mantras. So one of the things I say is survivorship begins the moment you're diagnosed, because we have to plan ahead. We have to take care of anything and everything that is bothersome to patients. And it's not just physical, it's the emotional challenge. And some people have more than others, and it's okay to admit, of coping with the cancer diagnosis, the immediate future, and then the short term, and even the longer term beyond that. There's a need for more formal survivorship programs. And this is something we recognize more in our field. And the University of Minnesota, we have a cancer survivorship program that is thriving for people at any stage of their cancer. And it's really important. Something I can revisit in discussion, but another thing I've learned over the years, not just for people new to healthcare and new to our cancer clinic, but even experienced doctors in other specialties. I have to say, palliative care is not the same as hospice, because I completely understand 1000% that the term has links and connotations that are not accurate, but it's hard to overcome them. Palliative care is supportive care. I always talk about that. We have board certified specialists in the last decade, including here at our university clinic, who I partner with. They don't replace oncologists. They are not instead of oncologists, but I feel like we can't do our job most effectively without their help, and they are immensely helpful. Sometimes it's just a barrier of overcoming the word palliative, but I refer basically 100% of my patients to them. I think they're just outstanding. I kind of go like this with my hand saying an umbrella, anything and everything bothersome to the patient and their caregivers, they stand ready to help us hand in hand with our team. And it can mean something different to every individual. Before I pass the baton to Kim, I just want to give a little preview of what she's going to say, what we can say for discussion. I'm saying this as I'm thrilled to announce that in partnership with the Colorectal Cancer Alliance, we're following a model after success. Why replicate? Why create new wheels? We can see what works elsewhere. And over the last year plus, we have looked to I Spy, which is basically a 15 or so year old nationwide network of breast cancer trials that have been immensely successful. And Dr. Doug Yee, our longtime cancer director, who had recently stepped down, but still here at the university, international leading breast oncologist, part of that leadership council. And now with the launch in December of Project Cure CRC and K-SPY, there are many facets to funding colorectal cancer research, but part of it is K-SPY. And so we will talk about that during the Q&A. And so I just want to put up the QR code if anyone wants to learn more about that directly. And these are some of the points that we will look forward to revisiting during discussion. So thank you.
Thank you so much, Dr. Lou, for giving such a thorough overview of colorectal cancer, stressing the importance of screening and prevention, and also just plugging some of the work that the Office of Community Outreach and Engagement is doing to address some of the screening disparities that we see in our state. So thank you for that. So now I'm honored to introduce our second speaker, Kim Newcomer. Kim is a 16-year, yes, you heard that right, 16-year stage 4 rectal cancer survivor and a dedicated advocate for patient-centered care and cancer research. She is now the new Senior Director for Research Programs at the Colorectal Cancer Alliance and is truly a respected voice in the cancer community. She serves on numerous advisory boards and steering committees to ensure that patient voices are heard in the center of cancer research and policy decisions. She currently sits on BI's Global Patient Advisory Board, Pfizer's CRC Steering Committee, among the many. She mentors through the AACR Scientist Survivor Program and serves as a stakeholder advisory board member for the Thrive MCRC study. With over 40 publications on patient-reported outcomes, Kim is such an integral part of the Alliance Cure pillar. She manages the CRC platform clinical trial to advancing personalized treatment, and this just demonstrates her deep commitment to improving survivorship and quality of life for colorectal cancer patients. Kim, we're so honored to have you here with us today. Please take it away and share your personal story with us.
Well, first, I want to thank you for allowing me to be on the call. I have a very heartfelt love for the University of Minnesota and the Masonic Cancer Center. So thank you for allowing me to be on here and sharing my story. Thank you to Dr. Lou as well. So since this is Colorectal Cancer Awareness Month, we're talking about screening. I'm going to get started by talking about how I was diagnosed with stage 4 rectal cancer at 35. So I was on a vacation with my husband and was not feeling well. And for the entire week when I was in the Dominican Republic, I thought something wasn't right. I couldn't go to the bathroom. I was having issues. So the moment I came home from my vacation, I went right to my primary care doctor. I knew colon cancer ran in my family. My father had colon cancer when I was 13. He was 46. So I thought, hey, I better go in and make sure everything is going okay, and that, you know, I shouldn't be getting screened earlier than 35, because I should have been, or 36, sorry, because I was 35, almost 35 at the time. So I went in, saw my doctor. He said, oh, you're healthy, you're training for a half marathon. He sent me home with some laxatives and said, if it doesn't clear up, you know, you can come back and we'll do more tests. So I came back another time and he said, oh, you know, it's nothing. I'm going to be really honest. He like looked and said, didn't really do a rectal exam, but he kind of looked down there and was like, oh, you're fine. So I was like, I believe my doctor. I didn't ask any other questions. I was happy I could put off my colonoscopy for another year. So time went on and I started having a cough. So I went to the doctor over the next 6 months, you know, every month for the next 6 months with the cough that wouldn't go away. I finally found a nurse practitioner who, as I was walking out of the clinic, said, hey, maybe we should take a chest x-ray. You may have pneumonia or something might be going on. So we took the chest x-ray and I headed off to get my latest prescription for my cough. The next morning at 8:01, my phone rang. I will never forget it. And they said, we need you to come to the clinic right away. So my husband and I went to the clinic and I sat down and the nurse practitioner was crying. She said, we found 5 tumors in your lung and 1 in your breast. I think you have breast cancer. So they sent me off to do a breast biopsy. I waited a week and a half, and then my test came back negative for breast cancer. So then they sent me for a lung biopsy, a needle biopsy. So I went in, they took a needle biopsy and said, oh, not cancer. You must have been have you been in Minnesota, upper Minnesota? There's a fungus going around. You may have a lung fungus. So I said, I'm up for whatever. So I had to wait 2 more months to get in to see a lung specialist. He did not even take me back to the room. He took me to the CT scan and said, hey, this is metastatic cancer. I'm not sure where it's coming from, but I have a friend who's a doctor and he's going to take that tumor out tomorrow and we'll figure it out. So the next morning I went in and had the tumor removed. I was wheeled into the room and my entire family was crying. The doctor had told my entire family, but had not told me that I had cancer. The biopsy had not come back yet, so they were not sure where did it come from. The next morning, a doctor came in and said, you have adenoid carcinoma, you have colon cancer, we're going to send you home, we're going to send you for a colonoscopy, and we're going to send you for a whole bunch of tests. So I had my colonoscopy, and they found a 9-centimeter rectal tumor, 1 inch from coming out of my body. And they also found the 5 tumors in my lungs, and it had also spread to my liver at that time too. I had 2 spots in my liver. When my doctor had come in the room, she had said, you know, you took that x-ray back in January when I was first complaining of constipation. At the very bottom of the x-ray, they found the shadow. And they said, oh, the rectal tumor was there the entire time. We just thought it was a shadow on the x-ray. So if you think about it, I started going to the doctor back in January where I had 1 single rectal tumor. And in August, I had 5 tumors in my lungs. And by mid-January or November 15th, I had 2 in my liver. So that is how fast my cancer spread. So I was very lucky to get in. I mean, very quickly, I started treatment on December 11th. I didn't really have any choices. The only test they gave me was a test for Lynch. And that came back negative because I have family history. I started chemo fast and hard. They said they were going to hit me with everything they had. I was going to a local community center. I didn't ask a lot of questions. I was still my husband and I were in shell shock. We weren't sure what to expect or what was even happening. Everything was happening so quickly. So I had 12 rounds of Fulfox or 5-FU with the pump with Avastin. And then I was scanned again and my tumors were starting to shrink. So I asked if I could possibly have a surgical consult. They didn't want to do a surgical consult. So I called the University of Minnesota, the Masonic Cancer Center, which was my lifesaver. I went in, I saw a wonderful doctor, Peru Vigata, and Dr. Andrade and Dr. Rothenberger, who were all for the surgery. They're like, let's get in there, let's do whatever we can. So I sent their recommendations to my doctor. I started going back to my cancer center. in Minnesota, and they were doing radiation. Everything was shrinking. Everything was looking good. I was able to have surgery at a resection of my colon. I had 54 lymph nodes removed. I had a lobe of my right lung removed and 5 other resections. Dr. Andrade is probably one of my favorite people in the world, Dr. Rothenberger. They are fabulous. They were amazing for me. And then I decided to switch my care over to the university hospital. I still continued on chemotherapy. My first scan out of surgery showed more lung nodules or more lung metastases. So we continued to chip away at those, taking those as we could. They were noticing on my scan that there was fluid in my pelvis. So we went in to do an ultrasound, but all of a sudden we realized when they went to do the ultrasound, they could not do it. I had radiation treatment at my other clinic, and they had not told me about dilators or how to prevent the canal from shrinking. They were radiating my entire pelvis. So at the age of 35, not only had my whole life been turned upside down, I was then facing the fact of infertility and the unable to have sex for the rest of my life. So it was quite a shock. I'm very grateful for the doctors and surgeons at the U who kept pushing for my treatment, kept supporting me. And they were the only doctors that say, like, I'm so sorry this happened to you. Their empathy, their caring, I put my trust in them. They were able to come up with amazing treatment plans, even when the chemo stopped working. Because we know back in the day, this was 2008 to 2012, there was not a lot of treatment for colorectal cancer. And especially for our KRAS, which we were looking at a treatment that was coming down the pipeline called TAS-102, which is Lonsurf, had not come out yet, but that was on my radar for coming up. Remember, I was not even biomarker tested. I had 0 patient advocacy information. I didn't have a patient navigator when I started. So I was very lucky to find the university, to have them give me options for my treatment, but not only options for my treatment, but options to live with the quality of life afterwards. They were able to get me into hyperbaric chamber treatments, and then also reconstructive surgery to help fix the damage of the cancer treatments. So now, 11 years later, I have been no evidence of disease. So I'm really grateful to the university. Their doctors are caring, you're loving, your entire staff. I cannot say enough about your facility, your doctors, the cancer center. I started volunteering at the Hope Lodge. I wanted to give back to the University of Minnesota, Masonic Cancer Center. I want to do everything I can to talk to patients, to get them to advocate for themselves, to get them to understand that, you know, there are good times and bad times in cancer. You may have something that your whole life is being put on the sideline, but you can still move forward. There are still options, and you can still have a good quality of life. So yes, thank you. I see my time is probably up. I see Anna's popping up on the screen. But yes, I do love University of Minnesota. I cannot say it enough, and you guys are the best.
Well, Kim, thank you.
It makes my heart full. It really does. So thank you for having me on here.
Of course, and thank you so much for sharing just your powerful journey. I mean, your experience really highlights that not only the challenges of facing a late stage diagnosis, but also the resiliency and the advocacy that comes from it. And hearing your story and your perspective, I think just should remind us all that these conversations are so important, because behind every statistic, there is a real person, a real story, and a need for change and to do better. And so now I'd like to bring back Dr. Lou into the conversation. So we're going to actually have a bit of a deep dive and have a more interactive conversation that bridges both the clinical and the patient perspective. And so we'll be exploring again the key issues again about early onset to colorectal cancer, the barriers to screening, treatment, and then also the role of advocacy. But if you've been to other fireside chats, you know that it's not a fireside chat discussion without getting our virtual fire started.
Yes. Oh, nice.
I like
Warming
that.
up.
Yes, we have to set the mood.
Yes.
So let's get us started with our questions. So Dr. Lou, you've mentioned we were seeing a troubling increase of colorectal cancer cases among younger adults. How are we responding to this trend in terms of raising awareness in younger people?
Yeah, I think, you know, a multi-pronged approach. So through organizations like Colorectal Cancer Awareness, through Colorectal Cancer Alliance and the other ones I mentioned, through people like Kim telling, in this case, her story on forums like this are immensely important. It's something that has to unroll over time because I don't know now if we think we're in our 20s and 30s, you know, colorectal cancer and cancer diagnosis is not the forefront of our minds, right? We're living life, we're doing things, we're trying to build career, maybe we're trying to build families and relationships. So this idea of I'm too young to have cancer, it may not be verbalized or said something concretely, but it may be not at the forefront of someone's mind. So I think, as I kind of was saying earlier, a little bit hand in hand, not just the general public and people, but also other people in medical specialties. So I think just primary care physicians being aware of it when someone does see a primary care physician, not to dismiss it as, oh, it's just a gastroenteritis. Maybe you have a stomach bug, maybe you have hemorrhoids, and that's why there's blood in your stool. These things are not normal, or they at least think you can't diagnose it unless you think of it. And so I think social media is a very powerful tool for amplifying messages like this, in addition to forums like this.
And then Kim, you were diagnosed at a younger age when colorectal cancer wasn't on your radar. So what was that experience like for you, and how has it shaped the message to others who might not think that cancer affects them yet?
I would say if I wouldn't have listened to my body, if I wouldn't have advocated for myself, kept going to the doctor. I didn't mention in my story, but one time I went to the doctor and they actually referred me to get mental help. You know, thinking that there was something wrong with me because I had all these complaints about what was wrong with my body. So advocating for yourself, you're never too young for colon cancer. You know your body. If you're not getting the answer you like from your doctor, go to another doctor, go see another doctor. Talk to other people. If you think you know someone who is having the same issues as you, talk with other people. I think that's really helpful. Sharing stories is really powerful.
And I mean, it's clear that the role of advocacy and also that awareness is key, especially for younger people and other folks who are not thinking about cancer. And so we're going to move on to barriers to screening and how to overcome them. I know, Dr. Lou, you kind of briefly talked a little bit about it, but Kim, I'll actually ask you this question. So we know that personal stories are powerful motivators for action. Have you seen examples where sharing your experience or connecting with someone directly has actually led them to get screened?
Yeah, I can actually say in my own family it has, because my cousin John was also diagnosed with stage 4 rectal cancer as well, on my mother's side. So different side of the family tree, right? But just because he was having those issues, he went to the doctor and was screened, and now he is also cancer-free at stage 4. But I see this all the time. We talk to patients, people message me on social media, they tell me their symptoms. I will say, hey, time for a colonoscopy. Even for my own husband, who has a history, his uncle died of colon cancer at 40. So I had to fight to get a colonoscopy. I literally sent a letter to his primary care doctor and was like, yes, he needs one. I'm telling you, he needs it. And he actually had 2 precancerous polyps removed. So it's like fighting for yourself, speaking up for yourself, speaking up for your loved ones, speaking up for your friends and family members, and sharing that message of when and how, what the symptoms are, when you need to be screened, and knowing your family history is so important.
I think that's key, like really knowing your family history, because you were able to start screening 10 years prior to your father's diagnosis. So I think having these conversations with younger folks is really important. So I'm going to actually move us on a little bit because Dr. Lou, you already addressed some of this question about some of the strategies that we're doing in your presentation. So we'll move on to the emotional and medical impact of a late-stage diagnosis. So Dr. Lou, when a patient receives a late-stage colorectal cancer diagnosis, what are the first crucial steps that they should take in terms of treatment and support systems?
Yeah, I think of the movie that came out in the last 2 years, Everything Everywhere All at Once. So, and I see part of my role. I mean, I Every physician, every medical team works differently. I'm very proactive, so I will review whatever information I have in hand before I meet somebody. I'm just giving an example. It's just, but there's so many ways for it to be approached. So I think if I can empower people with information and translate it into regular language, and by the end of a first visit, provide the reassurance that I aim to do and say, because of all these tests have already been performed before I'm meeting you, I can formulate, while we're sitting together, a plan, and here are the steps we're going to go forward. And it might be a lot. It is a lot because it's a multi-step thing. And so whether it's taking notes or however, so it's not just like one item and go do this and then come back in 2 weeks. So it's a lot of things, but it really galvanizing my team. So I tell people really I might be the least important part of the team, which I think is the truth. So we have physician assistants and nurse practitioners that day to day, week to week will help manage. We have outstanding chemotherapy infusion nurses who are really astute. And I just, after 13 plus years of working with them, I just trust them so much. And when they give me a call, I know it's something like serious. We have my nurse care coordinator, who's a kind of the first line or our triage nursing team, when people call day or night or on call, team members, that if someone has concerns, say, let's not sit on this, let's take this seriously, let's try to address it proactively if people are getting pain or other symptoms. But when I first meet with somebody, my ideal scenario is if I recognize that something's missing, I try and order it, if it's a week before or 5 days before, and see if we can rush to get something done. So that way, by the time it can be more satisfying to somebody that I can say, I have everything I need. I don't need to send you away for a week and then come back and see me again. Then I can give an answer. So that's part of the effort. For colorectal cancer, it's a lot of things. It's staging. So the staging depends on, I'm going like this, including lungs. So basically from neck down, usually a CAT scan, chest, abdomen, pelvis, we call it, basically from the neck all the way down to the lower part of the body, to get an idea where things are. It helps us determine stage. If we need other tests, we'll get it. Sometimes blood tests. With growing technology in the last few years, that has been very exciting. There are ways to check DNA that tumors shed into the bloodstream that might have implication for prognosis. But basically, there are other things like power ports, Kim and team know about. So I say it's a device installed under the collarbone here in the vein. And for basically the tried and true chemotherapies that we use, international standard of care, require these devices because they're infusional chemotherapy. So it's kind of like trying to set those things up, and I work with my team and hopefully try and expedite things as much as possible, because I know by the time people have met with me, before they meet with me, after they meet with me, they're anxious to move forward with the care.
And then Kim, for you, what advice would you give to someone who was just experienced or was just diagnosed with a late stage cancer?
I would say connect with the patient advocacy group if you can. I know the Alliance has patient navigators, nurse navigators on call that can help answer those questions. I think a lot of times patients go into their first appointment and there's so much information, and doctors only have so much time and nurses only have so much time, and then you get home and you may have those questions. We have an awesome helpline with patient navigators who can help answer those questions and help guide them through some of those decision-making steps. We have some resources that are trees that can help you make those decision-making trees, making sure they have biomarker testing. We know not everybody has access. I know the University of Minnesota's Masonic Cancer Center is fabulous. They do all the right testing, but not everybody has biomarker testing. Make sure they have biomarker testing, and make sure you feel comfortable with your doctors. I was scared to change oncologists midway through. It saved my life. So the University of Minnesota saved my life. I feel like make sure you feel comfortable enough to ask those questions and be comfortable enough to leave. I've switched doctors, oncologists 3 or 4 times. Some have left the U and I've gone into new. I've moved on to different parts of the country. I've changed oncologists, but make sure that you can have those open and honest conversations.
For that. So we're gonna transition a little bit to advancements in treatment. Dr. Lou, can you share some of the most promising advancements in colorectal cancer treatment that you think will significantly change patient outcomes?
Yeah, absolutely. I think picking up on what Kim said, the genomic profiling, it went from being cutting edge to 10 years ago to absolutely a standard of care. And there are studies that show that even at large centers and rural centers, suburban centers, everywhere in between, we're not meeting that need of 100% of patients. It is standard of care, period, end of discussion, for patients with stage 4 form of colorectal cancer should and deserve to have genomic profiling performed. it is unacceptable in 2025 and for many years in the past to not have that done. But we're still working as a research community and an oncology community to ensure that that happens, and we have a long way to go. I always kind of say that there's a near certainty. There is a certainty that genes will be uncovered, but the chance that there will be a gene that will mean there's a drug target and a clinical decision making is not 100%. It's not 50%. It's well less than that. It's in general, I might say 20% or less, but more are on the way. So 40 to 50% of all colorectal cancers are driven by a variant of a gene called KRAS. It's prevalent in about 20% of cancers. It was called the great undruggable target by the National Institutes of Health for decades. It is no longer, I mean, this is with NIH funding and research funding over decades. It started in the labs, worked its way up. And in the last few years, we've seen the fruit of about a dozen variants. There are drugs that fit the lock and key, the drug that fits the target. So now when I send off a patient's tumor for genomic profiling, if I see that, now I say, compared to 5, 6 years ago, I was not able to say this would make a difference, but now it makes a difference potentially. If this treatment and that treatment do not work, then here's an option. And it's less, is because of the clinical trials that have gone through that have proven that not just in theory that something should work, but proof in clinical trials, it expanded. And there's really been a great expansion in the last 5, 6 years and the numbers of treatment options. I would just say in comparison to like malignant brain tumors or pancreas carcinomas, pancreas cancers, and that are really just, you can count on one hand, if that, how many options are available. Now there's a wider array of chemotherapies, targeted agents, and other drugs for patients with colorectal cancer.
And it's amazing to hear just how far we've come in terms of treatment and where we're headed next. So Kim, as somebody who has been living with stage 4 rectal cancer over the past 16 years, how have treatment advancements played a role in your survivorship journey?
Ooh, well, treatment advancements, for me, I'm KRAS, so there's not a ton of options for me. I ran out at Full Fury was one I had a terrible reaction to, but I still did like 35 rounds. But Laura, I think long-serve, but for me, there's not much left. I've been really grateful that we've been able to keep my tumor burden down, and we were able to surgically remove the tumors. I think Dr. Andrade said he just cherry-picked them out as they were popping up and staying on the Avastin, but I was very lucky that for some reason, as my oncologist said, we did all this to cure you. Your body just figured it out. We don't know why, but we hope this will happen for all of our patients, right? Like, don't ask the why, just be happy that your body figured it out and we were able to cure you. So I kept always asking, why me? Why? And she's like, you should be happy. We did all this treatment to cure you. So you've been through a lot, don't discount what you've been through. So I'm just always grateful for the Masonic Cancer Center and the doctors. They're fabulous. So I keep going back to that. I just love you guys. I hope you know that.
We're grateful for the love.
We feel the love. And so while we have you, so how have you seen patients and caregiver advocacy make a difference in terms of research, policy, and patient support?
Well, sharing patient story, I think, is a big key. We need more patients sharing their story, reaching out to their local state, especially with the biomarkers. We know that biomarkers are not covered by every state. It's a state-by-state process. Reaching out to your local lawmakers, reaching out on Capitol Hill, sharing your story. I think your story is so powerful. So sharing your story and reaching out locally to your government is very helpful. I know we don't have much time. I could go on and on, but I'm trying to keep it short now.
And then Dr. Lou, how do patient voices shape the future of treatment and care from a medical and researcher perspective?
Kim, you were doing great. I couldn't say it any better, really. But I think the aspect of partnership, I think is increasingly recognized. The last decade, I mentioned the ACR Scientist Survivor Program. So Kim and I will be part of that. And that's something 25 years plus strong. And I think it's something where you're kind of meeting in the middle. I feel like it's the overall healthcare has changed, I'll say the last half century, right? Traditionally, it was like you go to a doctor, they tell you what to do, you do it without questioning. And it's also very much cultural, right? So I come from a culture where traditionally where doctors are highly revered to the point where you don't question them or at the risk of offending. And I think that's all out the window in the 21st century. There's the I would say the rise of the internet makes me sound old, but social media also, but like where one can access information. And so I think where the partnership is coming into it, like Kim has said earlier, I think just so beautifully, that it's a partnership. And if you don't feel a kinship or partnership, and I will be the first to say it, I tell people this, I'm not the right doctor for everybody. Someone might get matched with me because I have a scheduled opening. And I tell people, it's okay to get a second opinion. I mean, you certainly don't need my permission, but also find a doctor that you feel that you connect with. Because I just feel like it's an intangible thing. It's not something you can measure, but it's truly important. And so you want somebody to feel that they're getting the best care possible. And so when you have that partnership, it's a powerful source of not just motivation. And I think I can't measure outcomes that way. And I wish I could say 100% of the time things end up better because of that. But I think it's a crucial part of the teamwork, coming meet in the middle. You tell me what your questions are. I'm going to try my best. I'm only human. You know, I think any doctor would say that as well, and saying, we're here to help you. I wish we can say in 2025, we can cure everybody of stage 4 cancer and have more Kims in the world. Researchers, I promise you, here, everywhere, we're trying so desperately. I know in the current climate, it is adding a frightening element about whether or not things that are happening now are coming to a halt, and whether things that should get off the ground in 2025, will they? So there's a lot of uncertainty. And I think at the end of the day, I don't know a single researcher or oncologist or other specialist, physician or scientist in the field who doesn't do it either because of a personal drive to help, or in some way to help people.
Thank you both for that. Beautifully said. And I think a beautiful way to just move us on quickly to rapid fire round. I want to just try to do this. But if you quickly, what I'm going to do, I'm going to ask you each a question, and I'd love short, one word or one sentence responses from both of you. All right. So one myth about colorectal cancer that you want to debunk. Kim?
You're too young for colon cancer, right? We know that. I'm going to say you're too young.
Yes. Dr. Lou?
I'll come back to my palliative care is not hospice.
Yes.
Love that. Okay. And then one thing that you want the audience to take away from our conversation today. Kim?
Be your own health advocate.
Yes. That's a good one. Dr. Lou?
I couldn't say it better myself, is not maybe be proactive, not passive. If something's wrong, you know your own body, speak up.
Love that. That was a beautiful way, I think, for us to conclude on. So thank you so much for playing along and for just giving such quick responses, practical tips, and actionable insights. And so we have had a flood of questions come in, and so we are so sorry that we've not been able to get through all of the questions today. But as Dr. Lou showed on his slide, and we'll share out his slide, you can always call the Masonic Cancer Center nurse line if you have any questions that you need clarification on, any resources, guidance on anything. Nurse Patty is there to support. And so with that, we are going to wrap things up here. So thank you both so much, Dr. Lou and Kim, for being here today. I mean, it's conversations like this that are so important in spreading awareness, empowering individuals, and ultimately making a difference in the fight against colorectal cancer. And I want to thank everyone for their time, for their thoughtful questions, and their engagement. And while we couldn't get through all of the questions, we encourage you to stay connected with the Masonic Cancer Center, as well as the Colorectal Cancer Alliance, for additional resources and information. And with that, just a few announcements before we wrap up. We'd appreciate your feedback. So at the end of the session, when you close out your Zoom window, a brief survey will auto-populate. So please take a few moments to complete it. Your responses not only help us improve future sessions, but you can also enter yourself into a drawing to win a prize pack filled with goodies from the Masonic Cancer Center. And the link to enter the drawing is accessible after you submit the survey. And mark your calendars for our next virtual fireside chat in honor of Esophageal Cancer Awareness Month on April 16th at 1 p.m. And fun fact, it's actually Kim's doctor who will be our guest speaker. And so he'll be talking all about the challenges of detecting esophageal cancer early, common symptoms, advancements in screening, and the latest research. And finally, be sure to follow the Masonic Cancer Center and Dr. Lou. He's very active on social media for updates on future announcements and events from the Office of Community Outreach and Engagement. Thank you so much, everyone, for joining us today. Take care, and we look forward to seeing you at our next Fireside Chat.
Thank you so
Bye now.
much.
Thank you.